Excited to start us off with Dr. Marysia Lawrynowicz, who's going to be talking about obesity in EM. Marysia, as you probably all know, is an attending physician at Hospital Center as well as at St. Mary's. She's the director of didactics for the emergency medicine residency. She's also a research mentor for medical students at Georgetown University, focusing on intubation, airway management across all 9 emergency departments. She's lectured, taught workshops related to intubation regionally and nationally. So, Marysia, I'll turn it over to you.
Thank you so much, Manish. Let me go ahead and share my slides. Imagine you're starting your shift and your coworker makes a really derogatory statement about a patient's weight. Chances are you don't really think twice about that comment. Or if you do, you pause, you make a note of the fact that it was really inappropriate, and then you move on. And I know this because I've heard these comments and I've made these comments. And that's because the pervasive cultural messaging regarding obesity is clear. It's a moral failure. Even in searching Adobe for an image related to obesity, this is the descriptor that I found. So why should you care? Well, the numbers speak for themselves. Almost 42% of the population is obese in the US as of March of 2022. And when researching this, the biggest thing that alarmed me is how little we actually know about this population. So I practice in DC and in Leonardtown, Maryland, and the DC area actually has the lowest prevalence of obesity in the US. Those of you who practice in Baltimore, you're going to be seeing slightly more obesity around the 33% range. But if you've practiced or if you are going to practice anywhere else in the US, you will likely see more obesity than you do here. And sadly, there's a huge amount of stigma in our healthcare system. Numerous studies have shown anti-fat bias amongst physicians, including those who have self-identified as either overweight or obese. We know that patients in the ED with obesity have longer delays in being seen. They're less likely to be offered an operative intervention, routine cancer screening, or a pelvic exam. And unfortunately, they're less likely to follow up with doctors and keep appointments, which leads to poorer outcomes with treatment. So what you do matters because how patients feel during their ER visit is going to impact their motivation to follow up. And while the messaging about obesity is everywhere, I can almost guarantee that none of you knew that obesity is currently being renamed to really capture the complexity of the illness and hopefully decrease some stigma around it. So obesity is going to be renamed adiposity-based chronic disease, or ABCD. In this new classification, classes 1, 2, and 3 obesity correspond to BMI ranges. And for the purposes of this talk, I'm still going to be referring to this population as patients with obesity, mainly because I really don't think that ABCD has caught on. But that does bring us to the title of our talk, which is the ABCDs of obesity in the ED. And so my plan for today is to discuss some evidence-based actionable points on the management of airway, breathing, circulation, and drugs in our patients with obesity. So let's start with airway. What makes airway manipulation in these patients more challenging? Well, they have less time to desaturation with decreased respiratory reserve and FRC. They will have increased airway pressures due to the weight of the thorax on the chest, causing increased airway collapse. And unfortunately, that leads to gas trapping and heterogeneous ventilation. And then they have a higher aspiration risk from abdominal compression on the thorax. When it comes to the anatomy, that can also be challenging. Neck circumference has been associated with difficult intubation in multiple studies, and there's multiple cutoffs that we use for this. And the supine position is really poorly tolerated in these patients. Part of that is from mass effect when the diaphragm moves cranially, compressing the thorax. And the second part is that head extension can actually be limited due to neck adipose. And then OSA at baseline means that there's a loss of tone and airway collapse during induction. So the ramped position is something you may have heard of. It was first coined by Rich Levitan in 2003. The original study was done in 7 cadavers, and this inspired a study on these 60 bariatric surgery patients. These patients were randomized into either ramp position or the classic sniffing position. They did MAC VL intubations, and then 3 blinded independent investigators ranked the best grade of view. and the ramped position improved laryngeal view, and this was statistically significant. I do want to go over the ramp position. The goal here is to really optimize ear to sternal notch positioning. Step 1 is elevating the upper body with towels or sheets. And step 2 is actually getting the head anterior to the chest so that the face plane is parallel to the ceiling. Other positioning things that can help is potentially reverse Trendelenburg to take the pannus off the weight of the pannus off the chest. And this can be used during both pre-oxygenation and intubation. So our pre-oxygenation strategies that we want to mention here, how do we really increase this time to desaturation? In your awake patients, I would consider non-invasive positive pressure ventilation or high flow nasal cannula. If your patient's already on BiPAP, keep them on this until intubation, or you can just start CPAP at 10, which is what a lot of anesthesia research has discussed. High flow nasal cannula, if your patient's already on it, just keep it on for apneic oxygenation during intubation. And for those of your patients who are not breathing spontaneously, always assume it's going to be difficult to bag them. So you want to pull out your best practices, use 2 providers, place nasal trumpets, employ the 2-handed jaw thrust, and place a BVM over their face at flush rate with a PEEP valve, and then a 15-liter nasal cannula underneath. I know it might seem like overkill, but the nasal cannula underneath the BVM is going to help blow the airway open, stenting the posterior oropharynx open. So let's transition to breathing. Again, what makes breathing unique in our patients with obesity? At baseline, you're going to see a change in respiratory dynamics with increased work of breathing, leading to increased total body oxygen demand. There's lower compliance in the system, and it seems that people argue whether this is due to the chest wall, compliance due to the weight of the thoracic cage, the lungs themselves due to atelectasis and decreased FRC, or some combination of both. And then, unfortunately, there's also VQ mismatching, which causes more airway closure at the dependent areas of the lung, which are better perfused. OHS is really multifactorial. It's this triad of obesity, daytime hypoventilation, and sleep disordered breathing. This causes that rapid, shallow breathing pattern that we can see in our patients with obesity, which predominantly ventilates the dead space, causing hypoxia and pulmonary hypertension over time. So what do we really know about best practices when it comes to breathing or ventilation in our patients with obesity? It turns out not very much. Even when reviewing all the articles I could find and expert opinions on ventilation, the recommendations are very vague, and most of what we know is actually applied from the bariatric surgery or anesthesia literature. Now, I would say in the past, high PEEP was recommended in patients with obesity. This can have some risks. High PEEP and alveolar recruitment can cause more hypotension because we decrease venous return to the heart. Low PEEP strategies, the concern there is there might be more hypoxia. So what's the optimal PEEP that we can use in our patients with obesity? It's really hard to answer this question in the critically ill patient, but when it came to the anesthesia literature, there was a study in 2019 that I really wanted to highlight. Here they randomized patients into a group that got PEEP of 12 with recruitment maneuvers or PEEP of 4 during their surgical procedure. And this study looked at a composite outcome by post-op day 5, including a respiratory failure, ARDS, bronchospasm, and there was really no difference in the composite outcome by post-op day 5. So maybe this indiscriminately high PEEP strategy that we had been using in the past is not really appropriate for our patients with obesity. So in terms of summarizing some of these ventilator strategies, I would say think about the minute ventilation, what your patient's minute ventilation is before you start the ventilator. That's the tidal volume and the respiratory rate. Your goal is going to be to match your pre-intubation minute ventilation, so be mindful of those changes in respiratory physiology. In setting the ventilator itself, remember that your tidal volume is set as 6 to 8 milligrams per kilo of ideal body weight, which is based on height. Research shows that even in obese patients who have acute lung injury, clinicians overestimate the necessary tidal volume, worsening lung injury. And then PEEP, historically we used to use these super high PEEPs in our patients with obesity. I'm going to say this is nuanced. Try to keep your plateau pressures less than 30. And what you can do to hopefully minimize barotrauma from PEEP is really focus on positioning. When obese patients are supine, they have more auto PEEP, which can either be remedied by just adding more PEEP or sitting them up. So when you can, elevate the head of bed, drop their legs so that the panis can sit between their legs, and that may actually do more than PEEP itself. And then finally, proning overall has similar benefits to the non-obese population, but there's an even higher potential for improvement here because of their baseline alveolar hypoventilation. So we're on to C. Now we're going to discuss a little bit of circulation and what makes our patients unique again. In our obese patients, we'll see an increase in blood volume and cardiac output by way of stroke volume. And then we'll see a decrease in systemic vascular resistance in our normotensive obese patients. Cardiac assessment can be very challenging in these patients. You'll get poor cardiac or fast windows. Abdominal adipose can really obstruct your IVC view. Access, particularly for A-lines, is more difficult if that's what you generally rely on. Some people argue for using a femoral central line straight off the bat or a single lumen central line in the brachial artery if you need just regular access. And there's some ECG changes that we also see in obesity. Blood pressure, unfortunately, may not really rule out shock in an obese patient who looks sick, and it can be very challenging to get a reliable blood pressure. As we know, blood pressure should really cover about 80% of the arm. But what do you do if you have a conical blood pressure cuff that's supposed to fit over a cylindrical arm? If the blood pressure cuff is too big, we know it's going to falsely lower our blood pressure readings. And if the blood pressure cuff is too small, it's going to falsely elevate them. So here I'm going to advocate for actually using a forearm blood pressure in this population. It was Marie LeBlanc and her group who did several studies relating to blood pressure measurement in our patients with obesity. They looked at intraarterial blood pressures versus forearm blood pressures with over 1,200 blood pressure measurements. And the forearm correlated better than the upper arm with a correlation coefficient of 0.9. The general trend we saw here was that we overestimated systolic and underestimated diastolic. And this group actually did a follow-up study, which I thought was fascinating when it came to the ED setting. They looked at two groups, our patients with obesity and control patients, again looking at intraarterial versus forearm blood pressures, but here they looked at the forearm blood pressure in multiple positions. And the conclusion is really what I want to highlight, is that the forearm blood pressure agreed when the patient was supine or when the patient was in this semi-Fowler position, pictured here, which is at 45 degrees of head of bed elevation with their arm down. So both supine or semi-Fowler with their arm down, that's the way that our patients actually sit in the emergency department. So the forearm blood pressure may really be uniquely suited for our setting. And then finally, we're on to drugs. It may not surprise you that our understanding of how obesity affects pharmacokinetics is really limited. Obese patients are actually excluded from most pharmacologic trials. We know that hepatic metabolism is affected. There's variable changes with hepatic blood flow that can be difficult to predict. Renal metabolism, you can actually see an increase in renal clearance if patients have normal renal function at baseline due to glomerular hyperfiltration. And then our volume of distribution is going to change. If you remember anything from pharmacology, which you probably don't, and that's okay, our volume of distribution is determined by how lipophilic a drug is. So these patients are going to require higher loading doses of lipophilic drugs, and then they will have a longer half-life during infusions. The method of the route that the medications are given will also change. PO may be affected by gastric emptying. Think about your bariatric surgery patients or gastroparesis. Sub-Q will be affected by poor circulation to the adipose tissue. And then IV and IM is challenging just due to access issues. Our general dosing strategies are based on total body weight or the amount that the patient actually weighs, or ideal body weight. Now, if you are dosing based on an ideal body weight, is a calculation based on the patient's height. If you accidentally dose based on ideal body weight when you should have used total body weight, you're going to end up subtherapeutic in treatment failure, which is no good. And if you dose based on total body weight when you should have used ideal body weight, you're going to end up super therapeutic with more side effects, and that's no good. And this is particularly important when you think about medications with a narrow therapeutic window, such as low molecular weight heparins, or medications with delayed presentation of harm, like antibiotics. So this is a table I put together after looking at a lot of pharmacology paperwork. There's a lot of discrepancies between experts, but I think this is generally safe. I would say if you have certain RSI medications that you predominantly use, just take note of if they're dosed based on total body weight or ideal body weight here. Ketamine is a little bit unique because it's based on lean body mass, but I think that's fairly similar to ideal body weight, and it's a really complicated calculation. In general, call your pharmacist for help if you need it. So ABCD, really not as easy as 1, 2, 3, but if you maximize your time to DSAT, think about your vent settings, use a forearm blood pressure, and consider whether medications should be dosed based on ideal body weight or total body weight, it just might be a little easier. And thank you.
Thanks, Marysia. That was fantastic. I have a couple questions, and we'll open up the floor to others as well. My first question is, I feel like we see a leg blood pressure cuff measured sometime. Can you comment on if you found anything about the accuracy of that?
Yeah, I have mostly seen that people mention that leg blood pressures are done. I have not seen a study that was as elegant on leg blood pressures as the forearm blood pressure. I really think forearm is probably the way to go. It's what we have the evidence to support. So I don't see any downside really to using a forearm blood pressure as long as your patient has the distal upper extremities.
Cool. Thanks. Susie?
This is super helpful, Marysia. Thank you so much. I just also, and it's a talk for another day, but it'd probably be a useful talk to have. I think the other thing we need to think about is when we just talk to patients, like you were mentioning at the very beginning, like day to day, patients who are either overweight or obese. I had a patient who came in for concerning chest pain and hadn't gone to the doctor about it because she said, every time I go to my doctor, all they talk about is what my weight is. So I haven't gone to the doctor in like 8 years. She was maybe 50 something. Any rate, and I said, oh, that should never happen. Health at every size is, she weighed probably 180. She's about 5'5". So not a very large woman in this category that we've been talking about. And I said, oh, this should never happen. We're going to bring you in and look at your chest pain and issues and all these things. And then I followed up on her, and her number one diagnosis on discharge from the hospital was obesity. It was really a shame, and then there you go, bye, like not going back to the doctor for another 10 years. So anyway, there's a lot to think about with this, but it is such a practical problem in the real time, and that sitting up can really save your bacon. Sitting a patient up, it's not a small intervention. So I really appreciate all the important facts here. Thanks.
I think sitting up, the positioning part really cannot be underscored. Like, we cannot highlight that enough, particularly if your patients are on BiPAP. Like, why not actually put their legs down inferior, let their bellies sit between their legs, elevate the head of the bed. Gravity should be working for you. And so instead of causing barotrauma with just increasing PEEP, sit your patients up.
I totally agree with that. And just to point out again, the new clear bag valve masks that I think we all have in our EDs have that built-in PEEP valve. What's your default setting? If you are intubating somebody who's apneic, do you start off at 5 or 10 when you're bagging?
So in general, some people advocate for not even bagging unless the patient is completely apneic. I would say probably PEEP of 10 would be my default. So you want flush rate through the BVM, the nasal cannula at 15 liters, hold a good seal over their face with the PEEP of 10. And then if the patient can respire there, that's enough. You don't really need to bag them. If you do need to bag them, I would do nice, very slow breaths and really not compress the whole bag.
And maybe last comment, I think that you're presenting some of this work at SAEM specifically on rocuronium overdoses. Am I remembering that right?
Yeah, so one of the research studies that we worked on together actually was looking at all the intubation data across all the intubations that occurred in all MedStar hospitals in 2019. We specifically looked at, it was etomidate and succinylcholine. Those two medications tend to be dosed based on total body weight rather than ideal body weight. And we are grossly underdosing both of those. So while we do better with rocuronium, specifically because it's dosed based on ideal body weight, and people I find during RSI tend to think 100, 120, 150, and they just have set numbers. So that's fine for rocuronium, but if you're using succinylcholine or etomidate, you need to increase those doses since those really should be dosed based on total body weight.
Great. Thank you so much. And I'm hoping you'll be around for the rest of the day. If there's other questions, please put them in the chat. We'll go on to our next speaker, Dr. Teri Penn. Dr. Penn has been an attending at Good Sam since 2014 and the ED Director of Quality and Education since July of 2023. She spends her spare time volunteering with the Global Medical Mission Group, participating in 5K and 10K races and finding new recipes to try. Her interests include global health, international missions, and pandemic preparedness, and she's going to talk to us today about the chemical takedown. Dr. Penn.
I'm going to talk about sedating agitated patients in the emergency department. Please forgive my voice, I'm losing it a little bit. Okay, so the importance of agitation management as emergency physicians. We often need to control violent, psychotic, or intoxicated patients who present a danger to themselves and to hospital personnel. Rational reasoning, bargaining, shows of force with security guards, and even physical restraints are sometimes ineffective in controlling the acutely agitated patient. Chemical sedation is sometimes necessary to prevent injuries to patients and staff and to allow safe physical evaluation and treatment. The goals of sedation are to rapidly achieve a calm and cooperative state, to minimize the risk of injury to the patient and to healthcare providers, and to facilitate the diagnostic and therapeutic process. Common causes of agitation include psychiatric conditions, so like psychosis or mania, substance intoxication or withdrawal. And then there's a special note about excited delirium, which is also known as agitated delirium or hyperactive delirium syndrome. It has been described as occurring suddenly with symptoms of bizarre and or aggressive behavior, shouting, paranoia, panic, violence toward others, unexpected physical strength, and hyperthermia. The term has been controversial and has fallen out of favor as a diagnosis. In fact, ACEP has recently disavowed this term altogether, just because of its use as an indication for excessive force in some notable police brutality cases. So kind of back to causes, we can also see delirium as a cause of agitation, as well as pain or discomfort. So our sedation options we're going to talk about today include benzodiazepines, antipsychotics, ketamine, antihistamines, and then other medications in combinations. So case number one, we have a 38-year-old male presenting with a gunshot wound to the left side of his neck, and he is understandably very upset. His workup has had normal labs, but his chest x-ray shows a left-sided pneumothorax. CT of the neck and chest shows no vascular or airway injury, just the moderate left-sided pneumothorax. Patient consents to conscious sedation and tube thoracostomy. He was given ketamine for sedation and tolerated the procedure well. 30 minutes after the procedure, he starts getting agitated and attempts to remove his chest tube. He was successfully verbally de-escalated twice, but continues to get agitated over again. A patient was determined to have an emergent reaction and then from the ketamine and then required sedation for his agitation. In this case, we would use benzodiazepines. So the class includes Xanax, Librium, Klonopin, Valium, Ativan, and Versed. We typically use diazepam, lorazepam, and midazolam for IM and IV administration. The most commonly studied benzos for treating acute severe agitation via the IM route are midazolam and lorazepam. They have a rapid onset, a short duration of action, and they're useful for sedation in anxiolysis. Common reactions include nausea, vomiting, hiccups, dystonia, amnesia, diplopia, and ataxia. It's not recommended for elderly patients as it can cause paradoxical disinhibition and increased agitation. It frequently causes respiratory depression and hypotension and may require higher doses if the patient is not naive to the drug class. reversible agent flumazenil can cause seizures if the patient is on a benzodiazepine on a daily basis. So we have the dosing here. Diazepam is only given IV. And as you can see, lorazepam, you use the same dose IM or IV, and midazolam, you can use 5 to 10 milligrams IM or 2 to 5 milligrams IV. Midazolam appears to be the preferred benzodiazepine as it does achieve the desired sedation endpoint faster than lorazepam after IM administration. All of these medications can cause equivalent levels of respiratory depression, inconsistent and deeper than anticipated degrees of sedation, and unpredictable duration of sedation. Case number 2, we have an 85-year-old gentleman with a history of dementia and frequent falls, presenting with a fall from his nursing home and a hematoma on his forehead. His vitals, we have a heart rate of 98, his blood pressure is 175 over 100, his SAT is 98% on room air. His exam is only notable for forehead hematoma and agitation. His exam is non-focal, he's flailing all extremities, repeatedly trying to get out of the stretcher. He is placed in 4-point restraints in a posy vest, but he still requires imaging and is uncooperative. Which sedative would you use? In this patient, we're going to use an antipsychotic. So we have first-generation antipsychotics, which include haloperidol and droperidol, and then second-generation antipsychotics, or atypicals, which are Geodon and Zyprexa. They are effective for agitation related to psychosis. However, they may have a delayed onset of action. Both groups exert their sedative and anti-agitation effects via antidopaminergic neurotransmitter effects in the midbrain, the subcortical regions, and the reticular activating system of the brain. They also have a QT prolonging effect, which is why they suggest EKGs prior to giving the medication. They can cause arrhythmias from the QT prolongation, tardive dyskinesia, cardiovascular collapse, and neuroleptic malignant syndrome. Common reactions include tachycardia, hypotension, dystonia, akathisia, hyperpyrexia, and hypertension. So the first generation antipsychotics, Haldol and droperidol, it's basically the same dosing for Haldol, IM or IV. For droperidol, it's 5 to 10 milligrams IM or 2.5 to 10 milligrams IV. In various studies where Haldol and droperidol were compared head-to-head, droperidol is favored as it was found to have equivalent or superior action compared to haloperidol. Droperidol is also thought to be optimal antipsychotic when treating agitation in the setting of hyperactive delirium due to its well-studied safety profile, wide dose range, and rapid onset compared to most other antipsychotics. So the atypicals include olanzapine and ziprasidone. As you can see here, the dosing for olanzapine is the same IM and IV, and ziprasidone is only given IM 10 milligrams. Among the second generation antipsychotics, olanzapine was found to be superior to ziprasidone in achieving adequate sedation at 15 minutes. It blocks potassium channels to a far lesser degree than other antipsychotics and is thus very rarely found to be the cause for QTC prolongation. Case number 3, we have a 22-year-old coming in by ambulance with history of polysubstance abuse and paranoid schizophrenia, found wandering the street. She has obvious signs of trauma with abrasions and lacerations on her arms and legs. She's reportedly agitated and not making any sense. The police were called on the scene to attempt to restrain the patient for transport to the hospital. Medics are requesting medications to sedate her. In this patient, we would use ketamine. Ketamine has been shown to be effective in sedating patients in the pre-hospital setting and as an agent for procedural sedation. It is non-competitive, highly dissociative sedative, and provides effective low-dose analgesia, procedural sedation, and general sedation. Rapid dissociation, favorable cardiovascular stability, and preservation of the respiratory drive make it a viable option for intramuscular administration for sedation. It acts on specific areas of the brain related to the perception of memory of painful stimuli, with potential for more global depression of consciousness as the dose increases. The 2 primary advantages to ketamine that make it a useful agent for the management of severe agitation in patients with hyperactive delirium is that it can be administered via IM route with a more reliable achievement of effective sedation compared to benzos and antipsychotics. And then it consistently has a faster onset of action when compared to other classes of medications. Common reactions include sialorrhea, nausea and vomiting, nystagmus, lacrimation, fasciculations, and emergent delirium. The dosing for ketamine, typically for sedating an agitated patient, is 4 to 5 milligrams per kilogram per dose. In the IM administration, the onset is 3 to 4 minutes, and it can last 12 to 25 minutes. A couple of things to consider when you're giving ketamine to a child. You want to give it with benzodiazepine and apparently to some adults to avoid emergence reaction, and then consider giving with antiemetics, as vomiting is common when the ketamine wears off. There are concerns over the safety profile of ketamine, and it's led to increased scrutiny for treatment of undifferentiated severe agitation. Multiple studies have demonstrated that ketamine administration can result in hypersalivation and laryngospasm. These effects may compromise a patient's respiratory status. However, the majority of these adverse effects are managed without intubation. Case number 4. We have a 30-year-old female with history of end-stage renal disease on dialysis, type 1 diabetes, uncontrolled hypertension, and bipolar disorder. She is known to use cannabis on a daily basis. She presents with abdominal pain, active retching, forcing herself to vomit, and she's screaming and throwing herself all around the exam room. The vitals are significant for blood pressure of 220 over 110. Her heart rate is 88, and her sat is 96% on-room air. We were able to get an EKG, which shows a heart rate of 88 normal sinus rhythm with signs of LVH, and her QTC is 450 milliseconds. Which medication would we use in this patient? So we would actually use antihistamines on this patient. Typically, we can use Benadryl or Phenergan. They have a rapid onset of action, and then they have the benefit of antiemetic as well as anxiolytic properties. They can also cause arrhythmias because of the QT prolongation, can cause seizures, toxic psychosis, and heat stroke. They can induce or worsen delirium in the elderly secondary to their strong anticholinergic effects. And then common reactions include dizziness, impaired coordination, headache, dry mucous membranes, paradoxical CNS stimulation, blurred vision, palpitations, diaphoresis, and erectile dysfunction. The dosing for both of these medications is the same IM and IV, 25 to 50 milligrams. Onset of action is 5 to 30 milligrams IM for diphenhydramine and 20 minutes for promethazine. The duration can last anywhere from 3 hours to 12 hours. So other medications that we can consider, and we would consider them if there is a limit to using the more common medications, such as allergies, polysubstance abuse, or ineffectiveness of using the prior medications listed. Antiemetics with antipsychotic properties include compazine, Reglan, and then Phenergan also falls into this category. They're less reliable for sedating agitated patients, and again, can cause QT prolongation. We can consider combination therapy like the B52, which is Haldol, Benadryl, and Ativan. And then the dosing here, Benadryl can be 25 or 50 milligrams. The Haldol can be 5 or 10 milligrams. And then the Ativan can be 1 or 2 milligrams IM. The problem with the B52 is that the combination has actually not been found to be more effective than just Haldol by itself or Ativan by itself. And then in some cases, typical medications used for agitation are ineffective, and the patient ends up getting intubated. And these are extreme cases, but they happen sometimes with our severe alcohol withdrawal syndromes, when you're giving higher and higher doses of benzodiazepines and it's not doing anything. Sometimes you do have to accommodate, paralyze the patient, and then intubate them. And then polysubstance abuse, which includes sympathomimetics or hallucinogens, which can be a notoriously, you can have ineffectiveness when you're using antipsychotics or benzodiazepines with these patients as well, as especially with substances like PCP It seems like the medications last for 1 or 2 minutes and then they're back to their original state. So I'm just going to give you a couple of cases that are not as straightforward because no patient is a typical textbook case. So patient number 1, we have a 30-year-old male, history of diabetes, autism spectrum disorder, morbid obesity, and schizophrenia. He has a known history of violence toward family members, has a short temper, and medication non-compliance. He was brought in by EMS for hyperglycemia and was agitated in transit. He arrived with police and EMS. His vital signs are stable. He's guarded but calm and cooperative during assessment and exam. He's found to have balanitis and hyperglycemia without evidence of acidosis. And it was actually about to be discharged after the nurses went over some hygiene teaching with the medication or with the patient. No IV access was obtained during this visit. During the teaching, the patient became angry and started lashing out at the nursing staff. He had to be physically restrained by security and the ED staff. Which medications would you use? Now, in this patient, a B52 is an option, but given the patient's size, IM access only, and history of multiple violent outbursts in the past, he's likely had to be medicated multiple times for these violent outbursts and may require something stronger. IM Zyprexa and IM Ativan are better options. They're longer lasting and have excellent antipsychotic coverage. This patient required all of these medications and actually ended up getting ketamine as well, which did not touch him. The thought was that because of his size, most of the medication was getting into the adipose tissue and not actually into the muscle. The patient did require being intubated and paralyzed and ended up doing fine after he was admitted to the ICU and brought off of sedation eventually. Excuse me. And then patient number 2, we have a 55-year-old male, history of hepatitis C, hypertension, polysubstance abuse, brought in by EMS for acute agitation, likely ingested some illegal substances, brought in by 4 medics and 2 police officers. We were unable to obtain vitals other than heart rate and oxygen saturation. His heart rate was 120 and irregular, and his SAT was 99% on room air. There's no evidence of trauma other than abrasions on his hands and wrists from the handcuffs. He was transported to an exam room and placed on a stretcher with hard restraints. And IMB 52 was unsuccessful in subduing the patient. What do we use? In this patient, again, B52 did not work, likely secondary to his illicit drug use, but he did get IM ketamine. We started with a lower dose just because of his age and the prior medication, but 2 milligrams per kilogram was enough to sedate the patient and allowed us to get a full set of vitals, labs, and IV access. A full workup was completed while the patient was sedated. So in conclusion, there are several classes of sedatives available for our use in the ED. You want to make sure to get as much medical history as possible to be able to tailor your medication of choice for the appropriate circumstances. IM preparations can be just as effective as IV. Even though onset of action is slower, the duration is often longer. And then some patients may require more than 1 medication or more than 1 round of medications to sedate. Make sure to assess clinically before giving an additional dose or before changing medication class. Any questions?
Thanks, Teri. Just to start off, there's a question in the chat. Is there any role for intranasal meds in managing these patients? It seems like it might be safer for staff to administer.
There is a role for intranasal medication. It's just not as well studied. And I believe the onset of action is not as well, it's not as, what's the word I'm looking for? Not as consistent as IM or IV medication.
Okay, great. And then there's a comment in the chat that says for the rapid takedown of patients or if nurses or patients are or us are at risk, IM midazolam has been the most effective drug for me. Immediate de-escalation, then add something longer acting on the back end. And I'm wondering about that. Both the midazolam instead of lorazepam, and then also droperidol instead of Haldol. Because I think in the data that you presented, droperidol seemed to be much faster acting than haloperidol. Is that right?
That is correct. And honestly, I believe the reason why we don't use droperidol as much is just because they had that black box warning back in 2001 for causing QT prolongation. However, if you look at some of the studies, it shows that one-time dosing for an acutely agitated patient, they do not see any indications of QT prolongation in these patients.
Yeah, I mean, that's been my own B52. I learned as well in residency, but I've kind of made that transition to droperidol and midazolam just because it's so much faster. But okay, good. Any other questions or comments for Dr. Penn? All right, thanks very much. We'll move on to our next speaker. Dr. Alex Koo. Dr. Koo is an emergency physician at Washington Hospital Center and at St. Mary's. He's the simulation education liaison for the Georgetown Emergency Medicine residency. He focuses and his interests include military medicine, trauma, team dynamics, exertional heat illness, and simulation. He enjoys backpacking with his wife and little girl and are expecting a little boy the day after the spring symposium, so tomorrow. Alex.
Hey, thanks for the introduction, Manish. Great to meet everyone. Happy Tuesday. And I'm just going to pull up my slides. So we'll talk about a little bit of some mindfulness on shift today. And thanks for Manish's introduction. I'm an ER doc at Hospital Center as well as St. Mary's. And so I just wanted to share this quick clip. This was my second MMA fight. You guys still hear me?
Yes.
Okay, so this was my second MMA fight as a burgeoning amateur punching bag, essentially. And so my strategy during this fight was to actually come in and strike, which means stand up and basically exchange punches too. But I did something unusual, which you saw, was that I wrapped my legs around my opponent, and that's called pulling guard. It's a very disadvantageous position during MMA. And let me just pause this for a second. It's a very disadvantageous position because your opponent can actually use gravity, strike down on you, and throw you on the ground, essentially. And that was not what I was essentially going for. Granted, I had a ton of things going through my head. And one of the things while I was warming up was my girlfriend at the time came over and she gave me a kiss on the cheek and she said, "Good luck. That guy's huge." And so you can imagine what's kind of going through my head at that time. And I was like, that guy is pretty big. He's a whole head taller than me. And the second thing was like, maybe I didn't cut enough weight. I should have dropped another weight class. And another thing I started thinking about was, my right hand is a little bit tight. I think the wraps are a little bit too tight. I don't think I can strike effectively. Maybe I should just go to the ground and go against what I actually had trained for, essentially. And so all these thoughts were kind of running through my head. And we have these every day. We have these in and out, basically emotions, these different thoughts that kind of is a ton of noise in our head. Wouldn't it be nice if we could just kind of organize it a little bit better from what we see on our left, this huge myriad of emotions, to something that's a little bit more organized, a little bit more calm? Well, enter mindfulness. What do you think when you hear mindfulness? I mean, we all think about the crunchy granola, like meditation, these yoga retreats, and sometimes maybe like corporate sponsored like lectures on the next kill diet or something like that too. Well, I'm gonna tell you, I'm no like yogi, I'm no like meditation master. I'll be honest, I'm just the ER doc that's just looking for a little more calm on my shift. And I want to share maybe a few things just to kind of discuss about mindfulness. I think the first thing why I like to discuss about mindfulness is this analogy of two arrows. And you might have heard like Buddha saying that life is suffering. And I think that's a dramatic way of saying things, that there is going to be suffering in life that is inevitable. This can be things as essentially like losing a loved one, or maybe that code that comes in during shift change that keeps you over your shift by an hour, maybe 2 hours, or maybe literally getting punched in the face. That's the suffering that we kind of experience in life, and that is inevitable. That is what we call the first arrow. The second arrow that we kind of talk about is this created anxiety, is created suffering that we make for ourselves. So for example, losing a loved one, you might feel guilt about not spending enough time with that loved one, or maybe the anxiety of what am I going to do without my partner or my loved one. the future thoughts, these anxieties that you feel. Or maybe when you get home late, you pull in late because of that shift, and you're thinking, oh, I'm not able to help with bedtime routine for my kid. I'm late for dinner. Like all these things kind of run through your head. Or maybe if you get punched in the face, you have a lack of confidence, you feel fearful. These are basically the second arrows that we kind of create for ourselves. The first arrow we can't avoid, but the second arrow is something that mindfulness focuses on and tries to kind of abolish from that standpoint. I always think in the ER, we can never control what comes through those doors, but we can control the way we feel about it. So there has been great studies to say that for healthcare providers, infusing like a 30-minute meditation session on their lunch break has been shown over several weeks to definitely decrease acute stress reactions, also help with mental well-being too. But I'll be honest, how many of you guys have 30 minutes on shift to kind of dedicate to meditation? Well, there's definitely been studies that say on basically an observation of basically 3 different hospitals, they basically follow around ER physicians and they just kind of tracked how many interruptions happened during that time. And there was on average 30 interruptions in the 180-minute observation period during a shift. That's averages to 1 interruption every 6 minutes. Can you imagine trying to do yoga or meditation for 30 minutes and then every 5 minutes someone hands you an EKG or asks you to come to triage to do basically a quick neuro exam for someone that they're worried about stroke? There's no way. On top of that, how much time do we actually spend on self-care or personal time? There's been also studies that show we spend as little as 5% of our time on the shift for what we call personal time. And this includes going to the bathroom, eating, taking a breather too. So, I mean, that's on a 9-hour shift, that's 27 minutes. So that's not a lot of time that we actually have for ourselves. And I don't know if we always want to be spending it just on mindfulness or meditation at that point. So I want to kind of discuss 3 simple techniques that you can do pre-shift, intra-shift, and post-shift that don't require a lot of time and are practical and hopefully are accessible to you. So number 1, what's your pre-shift ritual? We talk about these rituals and we might not like this explicitly talk about them, but we do it all the time, whether it's your bike to work, whether it's chatting with a colleague right before shift, or for me, it's personally taking a sip of hot coffee at the moment, right before a shift. And so we all have these pre-shift rituals, but it's just leveraging it a little bit more. So during these pre-shift rituals, it's a good time to practice mindfulness of being present in the moment and not worrying about future anxieties, not worrying about any past issues or anything. So while you're pedaling the bike, you're focusing on basically wind in your face, you're thinking about like that burn in your quads. You're not thinking about what the waiting room is doing. If you're talking with a colleague, you're focusing on that conversation at the moment. What did your colleague do over the weekend? Or what's their vacation plans from that standpoint? And for me, when I take a sip of coffee, I'm just thinking about the flavors that I'm kind of tasting, the hotness of the coffee. And so it's just kind of bringing yourself to the present and hopefully calms your nerves a little bit before shift. Number 2 is on shift, you can practice breathing techniques that are very accessible. So something that's very commonly taught is something called box breathing. Simply, you take an inhale for 4 seconds, you hold your breath for 4 seconds, and you exhale for 4 seconds. This has been shown and definitely in military and then also in different high stress scenarios to definitely decrease someone's stress, also increase marksmanship. To the right of this picture, this is actually me with the Rangers, and we're doing some basically techniques of box breathing before we do room clearing under night vision. And this can be a stressful situation. These rooms are set up that you don't know if there's an enemy combatant behind the door that also has a weapon. And so we basically practice this box breathing before we enter a room. And so this can be practiced at anywhere. It definitely calms you. It definitely helps increase your marksmanship. And I think definitely can, on shift, can definitely diffuse a difficult scenario. When do we do this? I typically do this when washing my hands. So whether I gel in, gel out, when I'm washing my hands, this is a perfect time to kind of practice box breathing, or it doesn't even have to be box breathing. It can just be focusing on your breathing, whether it's taking a few seconds in, a few seconds out, to kind of focus yourself and recenter. It's also great for patients too. Sometimes if a patient's very anxious about a technique or maybe that laceration repair or something, or of course, the impending intubation, it can be very scary for the patient. Coaching them to kind of talk about their breathing, focusing on breathing through their nose and out through their mouth can help alleviate some of the anxiety, not all of it, but some of it. And then lastly, I want to talk about expressing gratitude. This is a picture from Temple, and it was from a failed resuscitation. We've all been part of these resuscitations. Look at this, it is crazy nuts. And I think the last thing we want to do after this really stressful situation is express gratitude. But I'll challenge you guys that it can really help you feel better about yourself as well as help someone else if you express gratitude. Think about this resuscitation. How many people were involved in that too? So your charge nurse might have got you early for this resuscitation. A tech might have stayed a little bit after or pitched in to do CPR. Or, I mean, look at this mess. Like, imagine our environmental services team members that are cleaning up after this too. This whole team makes this resuscitation work, and I think definitely there's been studies to show that expressing gratitude, or even the thought of expressing gratitude for these people, can definitely help with your mental well-being. So maybe after shift, you might go up to your charge nurse and say, hey, thanks for grabbing me for basically that resuscitation, or that tech, thanks for staying after doing great chest compressions, or your environmental service employee, and be like, hey, thank you so much. I know that was a ton of mess and I know it's a huge deal, but thank you so much for helping out with that. I did want to caveat, there are some moments that mindfulness may not be always the most appropriate. It puts it on the individual. And number one is sometimes there can be personal injuries that we kind of deal with. There can be personal traumas or memories that we may not be ready to deal with. Mindfulness requires us to kind of face these emotions, and we might not be ready. So definitely we do things like compartmentalize, and that might be more appropriate in certain instances when dealing with different traumas too. Number two is also, as I said, it puts it on the individual. But if there's a systemic issue with whether organization or leadership or anything, then it's not necessarily fair to put it on the individual to say, hey, just fix yourself, become more resilient. We have to do something with the organization to make it better. I've been part of a lot of great military units, and some military units that probably needed a little bit more work, better leadership too. I remember we would have mandatory, what we call resilience training, where every year they basically make you focus on your breathing, think about how you can improve your own situation. But really when the issue was within the organization itself too, or your leadership. So I think I just challenge, if there's something wrong systemically, it's kind of like asking someone in a burning home to just hold their breath longer, essentially, when really the issue should be putting out the fire for the home too. So I think if there is something, I would say mindfulness is a good way to deal with certain things, but it's not always the end all be all. So just to kind of recap, so leveraging your pre-shift ritual, how can we kind of infuse a little bit mindfulness before our shift, the art of breathing on shift, and then also expressing some gratitude at the end. Of course, I lost that fight pretty badly, and Jen always tells me how it is. She tells me it straight up every time, in terms of clearly that guy was bigger, and he was a lot stronger. He was better trained too. But I won't take the fact. I take the facts at face value, but I don't let the emotions kind of get in the way as well too. This is our little kid Zoe, and we'll be expecting a new one tomorrow. Thanks, you guys. I appreciate your time.
Thanks, Alex. That was really fantastic. Any questions or comments for Alex? There's a bunch of things in the chat, including Blue Team doing some box breathing last night. But any other questions or comments for Alex?
Do you mind if I ask how box breathing went? Like, did you guys do it at the team huddle, or was it before resuscitation?
Yeah, I think it was just being discussed. Diana, do you remember?
Yeah, sorry. Yeah, it was mostly Quinn and I just did it at the desk, and Manish and Jake Isserman and I were talking about it and just brought it up, and couldn't remember the term, and someone was coining triangle breathing. But the point being that we needed to take some breathing. We breathed all together, and it was very good.
That's the most important part, focusing on your breathing. Doesn't matter if it's a triangle, a circle, a square, whatever you want.
A key member of which is Dr. J.V. Nable, who's written the definitive review article published in the New England Journal of Medicine on in-flight emergencies. He's been an emergency physician at Georgetown for the last 10 years. He's an associate professor. He's the fourth-year clerkship director of emergency medicine at Georgetown. He's also the medical director for the Georgetown EMS and EMS liaison for the Regional Emerging Special Pathogen Treatment Center at MedStar Washington Hospital Center. JV is also maybe the only or one of few Golden Apple recipients several years in a row, to the point of being, what is it, the orchard? Like, I think to the point that you can't get another award for a period of time because you keep getting them. Is that right, JV?
Yes, I was put into the orchard last year, so thank you so much.
Yeah, what a treat. Thanks for speaking with us.
Appreciate it. Thank you so much for that introduction, Manish, and really, really honored to be here this morning. So I want you to imagine that you are on your next flight. When midway through the flight, a flight attendant gets on the PA system and asks, "Is there a clinician on board?" And you hit your flight attendant call button, whereupon you are then summoned to the back, and you are asked to evaluate a 40-year-old male having chest pain. Or hopefully it's not one of these wild cases that we've seen in the news, someone having a massive GI bleed, or someone having massive diarrhea all over the aircraft. So what do you do, and what can you do? Well, today we're going to be talking about in-flight medical emergencies, and just like any talk, we need a roadmap, or in this case, a flight path of where we're headed. First, we'll talk about the physics of flight and how it can contribute to the development of acute medical events. Then we'll talk about some of the resources available to you should you decide to help. And then finally, we'll discuss some of the legal implications. Now, first, though, I'd like to talk about some statistics. Unfortunately, there is no centralized reporting system to which all airlines must report these types of medical events. And so it's a little bit difficult to figure out how often this is happening, other than some research that's been put out there. And so every airline contracts with a ground-based consultation service, and that's because there isn't necessarily a healthcare provider aboard every single flight. And so flight crews need to be able to call somebody in the ground and say, "Hey, we have this person having chest pain. What are we supposed to do?" And so the researchers of this study queried the database of a ground-based consultation service that does its service for approximately 10% of global airline traffic. And over about a 2.5-year period, there were nearly 12,000 in-flight medical events that this service rendered assistance to. So this is happening every single day, multiple times a day across the globe. And one key takeaway from this slide I'd like for you to notice is that the types of medical events that are occurring, these are things that we see each and every day throughout our emergency department shifts. So I think we should feel comfortable in handling these types of scenarios, right? Syncope, respiratory issues, nausea, and vomiting. We are very comfortable to be able to take care of these types of emergencies. Also, some history is important to give some context. So in 1930, a woman by the name of Ellen Church was hired by what would eventually become United Airlines. She happened to be a nurse, and she set a precedent because after her, every single flight attendant that was hired by US-based airlines was a nurse. And this was primarily for one major reason. In the 1930s, airlines were getting into accidents and crashing at an astonishingly high rate. And so they wanted somebody aboard these aircraft to be able to calm an understandably anxious flying public. The other added benefit, though, was that anytime someone had any sort of medical issue aboard a flight, there was always somebody that was medically qualified and trained to be able to render assistance. World War II happens, and this requirement that all flight attendants be nurses was dropped so that their efforts could be diverted to the war effort. And for decades after World War II, there really was no national governing policy in terms of how we handled in-flight medical events. Flight attendants would routinely get on the PA system and ask, "Is there a clinician on board?" And many healthcare providers were really reticent to offer any assistance for two major reasons. One, they didn't know what their liability was. And number two, they weren't sure what type of equipment was available to them should they decide to help. In fact, until the 1980s, when you joined the American Medical Association, as part of your welcome packet, there was a list of suggested items that the AMA recommended you fly with in case you needed to render assistance. And so this culminates in 1998, so this not that long ago, with the passage of the Aviation Medical Assistance Act. And this act did two major things. It standardized onboard medical equipment, or required the FAA to do so, and provided liability protection for both airlines and assisting providers. Now, is there something special about flight and the physics of flight that may render someone more likely to develop an acute medical event? Well, you may remember Dalton's law. So Dalton's law asserts that the total pressure of a gas mixture is equal to the sum of the partial pressures of the component gases. And so this means as we go up in altitude, when air pressure goes down, the partial pressure of oxygen will go down with it as well. Now, commercial airliners fly somewhere between 28 to 45,000 feet. Now, they're all pressurized, but for a variety of reasons, they're not pressurized to sea level. They're pressurized to somewhere between 6 and 8,000 feet. And at 8,000 feet, you are breathing in air that gives you an alveolar concentration of oxygen of only 59. Now, for the vast majority of passengers, for the billions of passengers that fly annually, this is not a problem, particularly those that are healthy, young, not an issue. However, if you have underlying lung pathology, pulmonary hypertension, or really bad congestive heart failure, an alveolar concentration of oxygen of only 59 could be a setup for an acute exacerbation of your underlying illness. And it is because of Dalton's law that passengers with these chronic medical issues are often advised to seek out advice from their primary care physician about whether they should fly, or if they do fly, whether they do need to increase their supplemental oxygen. Boyle's law asserts that the volume occupied by gas is indirectly proportional to the pressure of that gas. So when air pressure goes down, which happens when we go up in altitude, then the volume occupied by that gas will increase with it. So which means you probably don't want to be sitting next to this person, somebody with a small bowel obstruction. There have been multiple case reports in the literature of passengers who maybe had a small ileus or a small bowel obstruction on the ground that become significantly symptomatic or develop perforated viscus during flight. It's also because of Boyle's law that a small pneumothorax can suddenly become a tension pneumothorax during flight. But big take-home point is this: for the vast majority of people, flight isn't an issue. However, for some passengers, particularly those with chronic medical issues, especially those involving the pulmonary system, flight isn't necessarily benign. So what do you do if somebody asks, is there a clinician on board? Well, a lot of what you can do is going to be limited by the resources available to you. The FAA, because of the Aviation Medical Assistance Act, was required to standardize the equipment aboard US-based airlines. And so when you ask for the emergency medical kit, this is what, at a minimum, you would be handed. You'd be able to take a blood pressure, you have a stethoscope, there's a bag valve mask, CPR mask. You have the ability to start IVs. And then in terms of medications, you've got aspirin, Tylenol, Benadryl, atropine, albuterol, D50, epi, lidocaine, and nitroglycerin. Now, one important thing about this is clearly not an exhaustive list. In fact, some would argue that rendering care in the skies is probably a form of austere medicine. These kits are not meant to be exhaustive. Airplanes and airlines are not flying clinics, so you may need to think outside of the box. In fact, one big thing that often comes up that is not included in the emergency medical kit at a minimum is a glucometer, right? And so you may be confronted with somebody who's altered, and all you'd like to do really is kind of get a finger stick, but that is not on the standardized emergency medical kit. And again, you'll have to think outside of the box. One thing you could potentially do is ask around the cabin and say, hey, certainly somebody has diabetes in here. Can somebody lend me a glucometer? That being said, you won't be able to assess the cleanliness of that device or the last time that was calibrated. But again, this is a form of austere medicine. You'll also have access to AEDs. And then also in terms of human resources, every flight attendant on US-based airlines is trained in CPR. And so if you're confronted with a cardiac arrest, you do have their ability to assist as well. A lot of people ask, well, whose decision is it to, say, land the plane, to divert that aircraft? Ultimately, it is not our decision as responding healthcare providers. We can provide a recommendation, and we should if we think that the patient's needs are critical. However, it's ultimately up to the captain. It's a very complex decision. There's a lot of factors to take into account. But our next take-home point is this, that airlines are not flying clinics. Again, this is a form of austere medicine. You do have access to limited onboard resources, but you may need to think outside the box. Now, what are your legal implications? Now, that Aviation Medical Assistance Act does provide you with liability protection as long as you're assisting in good faith and without gross negligence. You also have to provide care that's similar to your training. So if you're a dermatologist and you've never put in a chest tube, this is not the time to do so. And then in terms of compensation, just like any sort of Good Samaritan law or Good Samaritan protection, it is highly inadvisable to request or accept any form of compensation because that would render the liability protection afforded by this act as essentially null. Now, there is no legal obligation to assist. That's not true all over the world. For example, if you're a licensed physician in Europe and you're flying through parts of the European Union and you're capable of doing so, there is a legal obligation to assist. I would argue, though, that there's probably an ethical and professional obligation to assist if you're able to do so. Now, in terms of the general approach that I think we should take when we are responding to these types of scenarios, first of all, I think we should ask ourselves, is it appropriate for me to render assistance, right? Many of us are flying because we're on vacation. Maybe you've consumed an alcoholic beverage or two, and it's probably inappropriate for you to render assistance at that point. We also should introduce ourselves and state our credentials. We should ask for permission to treat, right? These aren't patients coming into our emergency department. These are first and foremost passengers out in public, and they may not want you to treat or assess them. If you think that the patient's needs are critical, it's our job to communicate that with the flight crew and consider diversion. Ultimately, not our call in terms of whether that aircraft will divert, but it is our responsibility to communicate, say, hey, I think this patient would benefit from an expedited landing. Make sure you keep a written encounter. In fact, every airline will provide you with some documents that you'll need to fill out, and you can request a copy of that. And then really big thing is don't request repayment. The legal literature is replete with case reports of physicians who sent bills to patients that they took care of up in the skies and had bad outcomes. Unfortunately, because they sent a bill, the liability protection associated with this act, the Aviation Medical Assistance Act, was not afforded to them. Now, some things to consider when you're rendering care in the skies. It's really crowded. In fact, it's probably more crowded than many of our emergency departments. So imagine trying to take care of passengers in this type of scenario. You may need to consider moving the patient, for example, to the galley so that you have a little bit more space. There's also no privacy. So imagine trying to take care of somebody who is going through childbirth. There's really no privacy. Also, remember that kit doesn't have every type of medication. So if you're confronted with someone with an acute behavioral health crisis, there are no sedatives. And so you'll have to think outside of the box in terms of how to handle that. And then if you're flying internationally, a lot of this is going to go out the window. First, the drug names on emergency medical kits on international airlines are all completely different. And then your liability and the legal issues are also different as well. So for example, if you are taking care of a passenger on Lufthansa Airlines and you're flying over, say, Austria, and you're taking care of a British national, you could be sued in 4 different countries. You could be sued in Germany because you're on a German flag carrying airline. You could be sued in Austria because you're taking care of somebody over the skies of Austria. You could be sued in the United Kingdom because you're taking care of one of their citizens. And you could be sued in the United States, which is your home domicile. At the end of the day, though, I think if you're doing what's right for the passenger and the patient, that'll at the end of the day carry the day. But our take-home point is this: at least in the United States on U.S.-based airlines, the United States does provide you with liability protection as long as you're assisting in good faith without gross negligence and without requesting or accepting compensation. I want to end with a case report from the British Medical Journal. This was on a British Airways flight from Hong Kong to London. And just before the departure, the flight attendant asks, is there a doctor on board? And there happened to be 2. There was an orthopedic surgeon that was asked to assess a passenger that was complaining of upper extremity pain after apparently en route to the airport was on a moped, fell off the moped, and was complaining of an upper extremity injury. The orthopedic surgeon said, maybe it's a contusion, maybe it's a closed fracture. Let's just splint it and let's go. So flight takes off, and 45 minutes after takeoff, that same passenger starts developing shortness of breath and tracheal deviation. So the flight attendants say, hey, can you reassess this passenger again? And the orthopedic surgeon correctly assesses that this passenger now has a tension pneumothorax and needs to put a chest tube. Now, there's no chest tube aboard what was then British Airways emergency medical kit, and there certainly isn't one now, and so had to improvise. And so what they did was they got a coat hook hanger and used that as a trocar. And then a passenger happened to have a spare Foley and used the Foley as a chest tube, and then use a water bottle as a water seal, and then use an airplane bottle of alcohol to cleanse the site. And I think this case really, again, highlights that this is a form of austere medicine. Again, you may need to think outside of the box. So in conclusion, in terms of what we've talked about today, remember flight is not benign, especially for those with underlying pulmonary and really bad congestive heart failure. Those patients could be a setup for an acute exacerbation of their underlying lung illness. If you do decide to render assistance, ask for the emergency medical kit. In the United States, you'll have standardized equipment that's available to you. Not going to have every drug in the formulary, but at least enough to potentially stabilize or provide some relief for that passenger until you're able to land. And then at least in the United States, there is liability protection afforded to you by the Aviation Medical Assistance Act. And with that, thank you so much. Really appreciate having the opportunity to talk on this subject, and I'll stop for any questions.
Great. Thanks, JV. That's fantastic. Lots of discussion in the chat. I'll just kind of read off some of these questions for you. The first is there information on non-US carriers on the medications and supplies available?
That's a great question, and it is really going to be country specific. Unfortunately, a lot of the drug names that's going to be one of the rate limiting steps. In fact, if you look at your Hippocrates, it's at its on its base setup, it's only U.S. drug name. So, for example, we all know that many of us probably know that paracetamol is Tylenol. But when you look at paracetamol, at least on the default settings on Hippocrates, it's not going to come up as that. And so you may need to figure out as you're traveling to change your drug names or et cetera on Hippocrates if you want to know the drug names and also the dosing. And then in terms of your legal liability and then legal issues, a lot of that is going to be really dependent on where you're flying, where you're coming from, and what type of and which airline you're on. Again, I think at the end of the day, if we are volunteering our assistance and doing what's best for the patient, that's going to carry the day.
Yeah, just another plug for us to be using generic names as opposed to brand names. Great. So another comment. I once was declined my offer to help on flight because I didn't have my medical license on me. Do you recommend we fly with that?
Yeah, that's a great question. And there's a lot of discussion about this. Both in the public press and then also putting on my EID hat. There are lots of, there are certain demographics of physicians that are often more questioned of whether they are a physician or not. So for those of you who are DC physicians, you have that wallet card that's available to you. I think Maryland used to do that. I think it's probably best, whenever you're traveling to carry that wallet card, or at least have a copy of that on your phone so that it's available.
One of our other physicians commented that they had a patient that medical control recommended diversion for chest pain. The patient refused to divert, but in the end, we were able to convince her to divert for further evaluation. Are patients allowed to refuse diversion?
Yeah, that's a great question. These are really first and foremost not patients, right? These are passengers of an airline, and so the airline doesn't have necessarily a responsibility to give care if they don't want it. And so it's a little bit of a different scenario than, say, when we're in a clinic or in an emergency department setting where we do have kind of that obligation to assist. That's not really the case on airlines. So the passenger says, hey, I don't want any help. We probably can't really force that passenger to seek help.
Great, and then I'll just read this comment in case someone is driving or not able to access the chat. ABEM has a downloadable board certification that you can put in your Apple Wallet. That was sufficient for flight attendants. We'll move on to our next speaker, Dr. Shannon Graf. Dr. Graf is the vice chair of the emergency department at MedStar Union Memorial Hospital, where she started as an attending physician in 2013, fresh out of her residency here at Hospital Center in Georgetown. She's a native Marylander and remembers a time when the Baltimore Ravens and Washington Nationals didn't exist. She spearheads the MUMH ED Peer Review Committee and reviews cases for risk management. Her other interests include process improvement, workplace violence prevention, critical care, fostering collaborations with other service lines, and being a mom to two amazing kids. Shannon.
So thank you, Manish, for that introduction. Good afternoon, everyone. Most of you all know me either from residency or at Union, where I've been for 10 plus years now. I am going to talk about posterior circulation stroke today, a topic that is near and dear to my heart, and I'm exaggerating there. I have no disclosure, so moving right along. Why is this important? So posterior circulation stroke isn't exactly the most riveting topic, but it's important to discuss. Our local peer review committee has identified posterior circulation stroke is a subject that keeps coming up repeatedly due to missed or delayed diagnosis. Patients with missed posterior stroke frequently present with nonspecific symptoms like dizziness, and it is most commonly missed because either the diagnosis wasn't entertained, the exam wasn't done adequately, or the appropriate imaging was not obtained. The outcomes of these misdiagnoses can be devastating for our patients, so it's worth a few minutes to review the details in hopes that future misses can be avoided. We'll start with a couple of cases of missed posterior CVA to highlight some of the pitfalls of making this diagnosis. Case number 1 is a 64-year-old female who was brought in by EMS for a chief complaint of intermittent dizziness. She had a history of hypertension. She's had vertigo and intermittent dysarthria for a week. She was originally seen at another hospital 6 days previous for the same symptoms. The physician who saw her reviewed the documentation from the previous visit and documented that she had an NIH stroke scale of 0 at that time, no ataxia noted on exam, and the patient had undergone EKG testing, troponin testing, a CT angiogram of the chest, and a dry head CT, all of which were unremarkable. She was diagnosed with mild vertigo, treated with meclizine and fluids, and ultimately discharged with PCP follow-up. She presented to the ED now stating that her symptoms hadn't improved. On her exam, her blood pressure was pretty high. It was 195/100. She was actively vomiting, and the treating physician documented an NIH stroke scale of 1 for mild dysarthria. The remaining neuro exam was unremarkable. There was concern in the medical decision-making for posterior circulation CVA. As her last known well time was greater than 24 hours prior to presentation, she was not made a code stroke or a candidate for thrombolytics. She underwent a CT and CTA, which demonstrated an acute thrombus of the basilar artery. There was a lot of edema and acute infarct of the pons, brainstem, and bilateral cerebellar hemispheres. She unfortunately had an acute decompensation while in the ED with worsening dysarthria, facial weakness, and ultimately appeared to have a locked-in syndrome. An NIH stroke scale was repeated and was now 13. A stat neuro consultation was obtained, and they recommended transfer to a thrombectomy-capable center for interventional neurology consultation. Shortly after she arrived at the other hospital, the patient underwent a thrombectomy. She did relatively well afterwards and ultimately was discharged to rehab with only mild deficits. Case number 2 is a 58-year-old female with a history of previous stroke and right-sided hemiparesis. It was unclear from the documentation if there was still residual weakness present at the time of this ED visit. She presented as a walk-in with a chief complaint of dizziness. She had reported 3 weeks of dizziness, which she had described as lightheadedness and blurred vision. On exam, no NIH stroke scale or visual field exam was documented. The neurologic exam was the typical boilerplate exam when you use your dragon dictation. The medical decision-making documented that the provider who saw the patient was not concerned for an acute CVA, and thus the patient was discharged with outpatient follow-up. She presented to another hospital's ED later that same day where she underwent an MRI, which demonstrated an acute versus subacute posterior circulation stroke. We'll quickly talk about stroke in general. Much of this information is included in the stroke chapter of our MEP Risk Reduction Core Curriculum book. Stroke is the second leading cause of death worldwide. There's an incidence of 16 million strokes per year. Prevalence of stroke obviously increases with age. Every year, almost 800,000 people in the United States have a stroke. Of these, 75% are new strokes, while the other quarter have had a previous stroke in the past. There's a high mortality associated with stroke, almost 18%. U.S. stroke-related costs are pretty astronomical, and this includes the cost of healthcare services, medications, and then missed days of work and potential costs. Stroke is the leading or a leading cause of serious long-term disability. It reduces mobility in more than half of stroke survivors over the age of 65, and 87% of all strokes are ischemic. About 20% of those ischemic strokes affect the posterior circulation. Importantly, posterior circulation strokes are 3 times more likely to be misdiagnosed than anterior circulation strokes, as the presenting symptoms tend to be pretty nonspecific, like dizziness. The posterior circulation, I have a little schematic over here, is comprised of the vertebral arteries, the basilar artery, the anterior inferior cerebellar arteries, the branch-like pontine arteries, the superior cerebellar artery, and the posterior cerebral artery. This supplies a large territory of the back of the brain, including the occipital lobe, parts of the temporal and parietal lobes, and this can vary in patients due to anatomic differences. parts of the thalamus, cerebellum, and brainstem, which includes the midbrain, pons, and medulla. This is a schematic of the brain region supplied by the posterior circulation. So again, portions of the medial, temporal, and parietal lobe are supplied by the PCA. Disruption of this circulation leads to memory deficits, alexia, which is disordered reading comprehension, acalculia, which is impairment of mathematical ability, agraphia, which is impairment in writing, and prosopagnosia, which is an inability to recognize faces. The occipital lobe is also supplied by the PCA. Disruption in circulation here leads to visual field deficits. Blood supply to the thalamus, at least part of it, is supplied by the PCA as well. Disruption here contributes to sensory loss or disturbance. The cerebellum, which is back here in purple, is supplied by the superior, anterior, inferior, and posterior inferior cerebellar arteries. Disruption in blood supply here leads to vertigo, ataxia, dysmetria, nystagmus, and the other traditional cerebellar signs. Finally, the brainstem, which is down here in red, is supplied by the basilar, superior cerebellar, and anterior inferior cerebellar arteries. Ischemia in this region leads to limb weakness and sensory loss. This is due to the presence of the long tracts that pass through this region. Cranial nerve palsies due to the position of the nuclei in the brainstem, and classic brainstem syndromes with cross signs, for example, Wallenberg syndrome or Pica syndrome, locked-in syndrome, which is a syndrome of mid-basilar artery occlusion, and top of basilar syndrome, which involves the distal basilar artery. This causes a syndrome of ataxia, hypersomnolence, and some other eye abnormalities. There's a high mortality associated with brainstem strokes. The 12Ds is a mnemonic device to help recall the symptoms and the signs of posterior CVA, and highlights why a careful history and physical in these patients is really vital to making this diagnosis. They include a devastating headache, which is typically occipital in location. There's some creative license here with this terminology. Dizziness is often vague, but can be described as vertigo, spinning, or a feeling of moving when the body is still. Disequilibrium, or a feeling of being off balance. Patients may describe feeling drunk. They may have dysconjugate gaze and diplopia. The patient may describe this as true double vision, or they might just say their vision is blurry. On exam, these findings can be subtle, so it's really important to examine the primary gaze as well as the extraocular muscles. Dancing eyes or bidirectional nystagmus we'll go over later when we discuss the HINTS exam. Dysarthria can be sussed out using the NIH stroke scale prompts when you do your speech exam. Dysphagia may present as new difficulty swallowing. The patient may have nausea and vomiting, which is described here as dyspepsia, and this is due to the feeling of disequilibrium. They may have dysmetria on finger to nose, heel to shin, and rapid alternating movement testing that you do on your neuro exam. And you may see certain deficits such as cranial nerve deficits, bilateral long tract signs like Hoffman's and Babinski. And some patients may have cross deficits if there is brainstem involvement. So what that means is there's ipsilateral cranial nerve deficits with contralateral motor and sensory deficits. The New England Medical Center Posterior Circulation Registry is a registry of over 400 patients with documented posterior circulation CVAs. Looking at their imaging and outcomes, patterns and trends were captured. The most common source of posterior circulation stroke is embolic. This is about 40% of cases. 24% of emboli were cardiac in origin. 14% were intraarterial. There's other etiologies, including atherosclerosis, dissection, which can occur traumatically or spontaneously, or less commonly, migraines, hypercoagulable disorders, vasculitis, and other causes. The most common occlusive sites include the extracranial vertebral artery, the intracranial vertebral artery, and the basilar artery. In 32% of cases, the large artery occlusive lesions caused hemodynamic compromise. 30-day mortality was fairly high at around 4%, and the patients who had the poorest prognosis had embolic mechanism, distal territory location, so things that are hard to reach, and basilar artery occlusive disease, which ends up affecting a very large portion of the brain and more critically the brainstem. From the registry data, the most common symptoms included dizziness, unilateral limb weakness, dysarthria, headache, and nausea and vomiting. The most common signs included, again, unilateral limb weakness, gait ataxia, upper limb ataxia, so dysmetria, dysarthria, and nystagmus. But please note that each individual symptom or sign is present in less than half of cases, and some of them in only a quarter of cases. So this is, again, why it's very important to do a thorough history and a detailed neuro exam on dizzy patients, including cranial nerve, visual field, extraocular muscle, speech, cerebellar, and gait testing, in addition to just the traditional motor and sensory exam that most of us do. You want to beware the term and diagnosis of vertigo. Traditionally, vertigo is a feeling of being off balance, and it's often described as a spinning sensation, but some patients actually describe a rocking feeling or feeling like they're on a boat. Very often, vertigo is caused by disorders of the inner ear, such as BPPV, Meniere's disease, and vestibular neuritis, which is typically viral. When considering central vertigo, or in other words, a posterior circulation CVA, think about vertigo plus other symptoms and signs. So in addition to dizziness, they may have diplopia, dysarthria, dysphagia, dystaxia, and other cerebellar signs. So have them walk, listen to them talk, watch them swallow, look at their eyes, and do a good extraocular muscle and cerebellar exam. These patients may also have motor and sensory deficits mimicking an anterior circulation CVA, so it's still important to do those components of the neuro exam. In a true posterior circulation stroke, these deficits will rarely be subtle or occur in isolation, but you need to know what to look for and how to do a good exam. So this slide is a little bit busy, but when considering peripheral versus central sources of symptoms, there are some factors that help you differentiate between the two. However, these aren't slam dunk differences, and there's some ambiguity and overlap. Vertigo caused by a peripheral nerve problem can present acutely and dramatically, or more gradually in the case of vestibular neuritis. The duration of vertigo is typically on the order of seconds to minutes, worsens with head movement, and is commonly associated with auditory dysfunction like tinnitus. Dix-Hallpike testing is commonly positive and causes a rotary, fatigable nystagmus when the head is turned toward the affected ear, and the associated neurologic symptoms are absent, as this is not a central problem. Vertigo caused by a central lesion, however, is typically acute in onset, can last for days to weeks. It doesn't really go away, and it may or may not be worsened by head movement. It's rarely associated with auditory dysfunction, and Dix-Hallpike testing is typically negative. Associated neurologic symptoms are very common, which can be elicited on exam. The nystagmus seen in peripheral nerve problems has a unilateral fast beating phase, either left or right, depending on the affected ear, and is horizontal or rotatory, but never vertical, and it typically fatigues after a minute. If you're performing a Dix-Hallpike, make sure that you observe the nystagmus until it fatigues. Nystagmus due to a central lesion is bidirectional. So what I mean by that is when the patient looks right, the fast beats tend to be rightward, and when the patient looks left, the fast beats tend to look leftward. It's non-fatigable, it doesn't go away, and there may be a vertical component. In peripheral vertigo, gait ataxia may be present, but truncal ataxia and cerebellar signs are uncommon. In contrast, central vertigo typically causes severe gait ataxia, with truncal ataxia and cerebellar signs as well. We'll discuss the HINTS exam next, which is comprised of 3 parts. The head impulse test, where we look for gaze correction, which is also known as a catch-up saccade. Nystagmus, which we've already briefly talked about, but in essence, you're looking for the directionality of the fast beating phase with bilateral deviation of the gaze. And test of skew, which looks for a vertical correction of the gaze when one eye goes from covered to uncovered. A great video resource is available on YouTube. It's called the HINTS exam by Peter Johns, who is a physician at the University of Ottawa. I encourage you to watch it. It's pretty quick, and it details the 3 components of the HINTS exam way better than I can do by verbally describing it. The head impulse test is the first step, and what you want to do is grip both sides of the patient's head so that you isolate the skull, ask the patient to relax and fixate on your nose, slowly move the head back and forth from right to left, having them fixate on your nose the entire time, and observe their gaze. While their head is deviated kind of maximally to the left, you suddenly want to return the head to the central position and watch their eyes. You're looking for a catch-up saccade, which is where the gaze will initially lag and then suddenly correct to look at the fixation point. You want to do this on both the right and the left side. In this case, abnormal is good. The presence of a catch-up saccade indicates a peripheral nerve problem, such as vestibular neuritis. Absence suggests a central lesion. Observing nystagmus is step 2. We've already talked about this, but it's good to rehash one more time. You want to observe the primary and lateral gazes. Have the patient first look at your nose and then have them look right and left. Unidirectional nystagmus is present when the fast beating component occurs only in one direction, and it's typically more pronounced when looking to the opposite side of the fast beating component. There's often a rotatory or torsional component. Again, this is reassuring and more typical of a peripheral source. Bidirectional nystagmus is concerning for a central lesion. You may see the fast beating component to the right when the eyes are deviated to the right, and vice versa. For the test of skew, you're going to cover one eye with your palm, have the patient fixate on your nose, and then quickly move your hand to cover the other eye. There should be no movement of the eyes when you switch. If you observe vertical movement, up or down, often accompanied by a little bit of a horizontal component, this is concerning for a central lesion. That said, don't hang your hat on the HINTS exam. When performed by neuro-ophthalmologists who have a ton of specialized testing and experience, there's data to show that this test is sensitive and specific. However, when performed by a cohort of ED docs, there's some data that the exam becomes less sensitive and loses quite a bit of specificity. It's a reasonable exam to perform to back up your findings, but it shouldn't replace a good history and physical. Regarding imaging, as in anterior circulation stroke, a dry head CT is not sensitive enough to rule out this diagnosis. It's actually far less sensitive for posterior circulation CVA than for anterior strokes. MRI is the most sensitive test, but CTA is actually fairly sensitive, faster, and more readily available, and it's also better at assessing for dissection if you're considering that. Treatment includes IV thrombolytics and mechanical thrombectomy. For IV thrombolytics, there's really similar benefits to anterior circulation CVA. Very few studies have parsed out posterior strokes from the anterior strokes when determining benefit. Interestingly, one recent study of basilar artery occlusion suggested that IV tenecteplase led to a higher rate of radiological reperfusion than IV alteplase. So maybe TNK is better than TPA. Endovascular therapies, in particular mechanical thrombectomy, is best studied and most often performed in basilar artery occlusions and not so much vertebral or PCA strokes. While controversial, thrombectomy may be beneficial to select patients, especially with earlier treatment and the use of aspiration instead of stent retrievers. Our neurology colleagues are the ones who will make this call, so be sure to engage them early. Mechanical thrombectomy is typically considered for posterior circulation LVO for up to 6 hours after onset of symptoms based on the AHA and American Stroke Association guidelines from 2018. In closing, I have some clinical pearls. Number one, consider the diagnosis of posterior circulation CVA. It's key to not missing it. Really think about this in patients presenting with dizziness, vertigo, nausea, vomiting, and dysarthria, and just do a really good H&P. Perform and document a careful and thorough neuro exam in patients with dizziness, vertigo, severe headache, or other neuro complaints. This includes not just motor and sensory, but cranial nerves, speech, gait, vision, and cerebellar testing. Consider the HINTS exam as an adjunct, but again, don't hang your hat on it. Dry head CT alone is inadequate to rule out this diagnosis. So if you have a really high concern, you need a CTA or an MRI. And consider expediting imaging if your clinical suspicion is high or if the patient is rapidly decompensating and maybe displaying one of these syndromes of posterior stroke. Remember that this is a code stroke situation if the patient presents within 24 hours. All right. So hopefully now you all feel a bit more confident about identifying and evaluating posterior circulation strokes. If anyone has any comments or questions, I'm at your service.
Thanks, Shannon. I'm not sure about feeling more confident. I think I might feel a little more terrified. There's a number of questions, comments in the chat, which I'll just read off a couple of them here. But I think kind of overall, summarizing some of them, it's like, how do you decide in whom to get an MRI? If a lot of what I'm hearing you describe is there's a number of patients that will have really minimum symptoms. How do you make that decision?
So I think a lot of it is just our clinical gestalt, right? It's really tough to say. You have to look for patients with risk factors. You have to, again, do a really good history. It's not enough to just say, oh, I'm dizzy. You want to nail it down. Like, okay, what makes you dizzy? What do you mean by dizziness? Do you have any of these other associated factors? And then, like I said, if it's really truly a central lesion, it's rarely going to present in isolation. So you if you're doing a really good neuro exam, you're really looking at their eyes, you're doing a good extraocular muscle exam, you're walking them, you're doing an NIH stroke scale, so you're assessing their speech, et cetera, I think it's far less likely that you'll miss it.
So a couple specific questions. Does intermittent dizziness versus constant dizziness have any negative predictive value for stroke?
I don't know the exact numbers. It's a good question. But intermittent dizziness is more typical of peripheral vertigo, whereas constant non-fatigable dizziness is more typical of a central source. Okay.
And then have you incorporated the HINTS exam into your own practice?
I have. It took me a little bit to get the hang of it, but it's pretty easy. It doesn't take very long. And patients think it's really interesting when you're kind of like jerking their head around. I've got to say, I'm not a neuro-ophthalmologist, and I haven't yet diagnosed a posterior circulation stroke based on my HINTS exam, but it certainly led me to maybe not order an MRI or further workup in some select patients.
And again, lots of comments in the chat. Maybe feel free to answer them afterwards or take a look at them and comment. But Jamie Gardner kind of summarizes it maybe better than I did of who do you not get an MRI in?
Yeah, so patients with clear-cut, peripheral symptoms. So somebody who has a positive Dix-Hallpike, who has fatigable rotatory nystagmus, who doesn't have a lot of risk factors, and who has had a good, thorough neurologic exam and does not exhibit any of the symptoms other than just dizziness.
Okay, great. Thank you again for that thoughtful discussion and presentation. And again, it'd be great if you can maybe take a look through and type in some responses to some of these questions and comments. Our last speaker of the day, Dr. Lauren Wiesner. Dr. Wiesner is the Associate Chair for the Emergency Department at MedStar Washington Hospital Center and the Associate Medical Director for the Regional Emerging Special Pathogen Treatment Center at Hospital Center. She served as the Director of Emergency Preparedness for her department over the last 10 years and is a former graduate of our EM residency program. Dr. Wiesner.
All right, step one, can you see my slides? Did I get that right?
Yes.
Okay, awesome. All right, so thank you for giving me a little platform to talk about special pathogens. I do this all day long, so I'm really excited to share a little bit with all of you. If I can get my slides to move, let's see. So here's what I'm going to cover really briefly with you. Number one, I'm going to try to define special pathogens with you, emphasis on try. I'm going to talk a little bit about the national response structure for special pathogens and what that looks like at the local level. And then we're going to hit the 3 critical ED steps, which is identify, isolate, and inform. So starting us off, what's a special pathogen anyway? It's actually a really good question. And special pathogens share one thing in common with pornography, and that's it's hard to define, but you know it when you see it. So there's a few characteristics to keep in mind that may make a pathogen special. One is that it can have the potential to cause high mortality among an otherwise healthy population. It may be a pathogen that there's no routine vaccine for, or there's limited therapies. It may have an unknown mode of transmission or be highly transmissible. And at the end of the day, it's really a highly infectious disease that has a high mortality rate. That seems to be the common theme for special pathogens. So you might be asking, like, why are you being so cagey, Lauren? Why don't you just give us a list of special pathogens? And the answer for that is it's a little bit tricky. The list can really change depending on what treatment options are available and the disease severity during an outbreak. So it's really a case by case that we decide whether or not something would activate our biocontainment unit. And really what we're weighing is the resource heavy use of opening a biocontainment unit versus the risk on the general population. And it can vary. So there is actually quite a strong hesitation at the national level for us to create a list, and different BCUs will activate for different things. And just a couple examples of that, COVID, it was a special pathogen when it first came out, but now we have a vaccine available. We have some treatment modalities, and the morbidity and mortality has significantly diminished, and so it's no longer considered a special pathogen. Ebola, if I mentioned if there's a vaccine available, that maybe that's not a reason for it to be a special pathogen, but even though we have an Ebola vaccine, we still consider viral hemorrhagic fevers to be our mainstay special pathogens because of that desire to really control those outbreaks and how incredibly virulent they can be. And then there's monkeypox, which kind of fits in the middle. Clade 1 is considered category A waste, and so we actually partially activate our biocontainment unit for a Clade 1 case in that we would use our autoclave within our biocontainment unit to manage the waste, but we would not activate for actual patient care. So there's kind of a little bit of an in-between there. There are a few lists that we tend to watch. Of course, there's category A agents. So those are your anthrax, botulism, plague, smallpox, tularemia, viral hemorrhagic fever. Those are all diseases that have been tagged as high risk to our general population, but not all of them are transmitted in a way that makes us need to open a biocontainment unit to contain them. In particular, botulism, tularemia, they just need standard precautions. So even though they're a high threat, you wouldn't have to activate a biocontainment unit. The World Health Organization actually does have a priority disease list. Now that list is really intended to focus their research and development, but it has a lot of the usual players on it, like Crimean Congo hemorrhagic fever, Ebola, Marburg, Lassa fever, but they also include things like COVID and Zika virus, which again is not something we would activate a biocontainment unit for. The UK actually did commit, unlike the US so far, and they have their own high consequence infectious disease list, which I've included on this slide here. And these are what they would activate their high level isolation units for. And so there is a lot of overlap that we would probably follow suit for most of these, but we don't have a specific official list here in the US. So what should you be looking out for? Basically, we're really talking about hemorrhagic fevers. That's the biggest category. But then we would be concerned for some pox virus diseases like smallpox, monkeypox. I give that little asterisk because we would manage the waste as category A. Nipah virus, maybe pneumonic plague, we would put in the biocontainment unit, cases of MERS or SARS, pandemic influenza. And then there's a catch-all of that disease X. So if something were to pop up in the world that's really unknown what it is, and it's a highly fatal disease, and there's evidence of person-to-person spread, that's where our biocontainment units really can shine and are important in our response. So what is our response? So in the US, we have RESPECTs, which are Regional Emerging Special Pathogen Treatment Centers. So these are ASPR-funded biocontainment units that are tasked with two main things. Number one is we're expected to care for 2 special pathogens patients at any given time, or 15 respiratory pathogen patients. And then we're also tasked with being a regional leader to do outreach for training and education for other hospitals, EMS systems, to be there to help coordinate care throughout our region. So what are the big picture goals for RESPECTs? Well, the big one is we're trying to prevent an outbreak. So it's trying to very safely contain a highly infectious and a highly lethal disease process, and then provide safe and innovative specialty care for those patients that do have the disease. We're supposed to be leaders in regional coordination, and ultimately, if there is an outbreak, the goal is to be a stopgap for hospitals so that we take those patients in the beginning to allow a hospital to have more time to prepare and create their surge space for a larger outbreak that would kind of span beyond what the biocontainment unit capacity is. So, of course, the reason I'm giving this talk is because we have a RESPECT at MedStar. It's at MedStar Washington Hospital Center, and we were designated a RESPECT back in September 2022, and we opened our 1F unit in January of 23, which, of course, is lovingly our ED observation unit on a routine basis. So it's a 6,800 square foot unit adjacent to the ED. It's 15 beds, and if we were to activate for a special pathogens patient, we have 2 patient care rooms that are connected by 1 anteroom. And the unit is really fully decked out for biocontainment care. There's a pass-through window that's negative pressure, so you don't have to continually open the doors to bring supplies in and out of the room. There's redundant negative pressure on the unit. We have our own dedicated autoclave, our own dedicated lab. There's, as you can see in the picture here, some surgical lights so that you can do in-room OR procedures, and the rooms are dialysis ready and all critical care ready. Our biocontainment unit team is critical care based as the primary team, and then we've created our own strategic service lines of specialties that can help support that critical care team for specialty needs like OBGYN, surgery, neonatology, of course, the emergency department, infectious disease, and anesthesia. So I want to give a little bit of a shout out to emergency medicine. We have a big emergency medicine footprint in the BCU, and that is in large part due to the support of MEP leadership. So thank you so much for letting us dip into your deep bench of talent. We're really grateful to have all of these players on our team. So that's our respect. There's actually 13 respects nationally. So originally they ASPR created 10 respects, and so that's 1 per FEMA region. And back in 2022, they expanded to include 3 new respects. So we're one of those new respects, and we share Region 3 with Hopkins. And Region 3 covers DC, Maryland, Virginia, West Virginia, and Delaware and Pennsylvania. So it's a pretty decent catchment area where we are, with Hopkins, create a regional coordination system for special pathogen care. And then NETEC, what that is, NETEC stands for the National Emerging Special Pathogens Training and Education Center, which is essentially an umbrella organization that brings together all of the respects so that we can create best practices and really make sure that all of the biocontainment units are ready and prepared at any time to take care of special pathogens cases. Now, the good people at NETEC are working on creating the National Special Pathogen System. So this is supposed to mirror our trauma designation system. So like a level 1 trauma center being the highest designation for trauma care, we have a level 1 special pathogen treatment center, which would be the 13 respects. And then they're building out so that we have more redundant care in the system, because if you have 13 respects and they're each expected to care for 2 patients, that means we have a full capacity of 26 special pathogens beds in the whole US, which is not a whole lot. So we need more. And so creating a system where there are level 2 treatment centers, level 3 assessment centers, and then really equipping all healthcare facilities to be able to do the basics of finding these patients and initiating care. All right, so what do you need to know in the emergency department? It's three main steps. The first one is to identify these cases, which sounds so simple, but it's actually really difficult in our environment. We have a lot of competing priorities in the emergency department. It's a chaotic environment, and so this is really low likelihood. Like, what's the chance that that patient with a fever is actually coming in with Ebola versus, well, maybe they have COVID, flu, or RSV, which we test for every day. So it's very low chance, but super high risk for us to miss these diagnoses. So if there's anything you take away from what I say today, it's please remember to ask a travel history. It all starts with being able to identify that case. And if we miss that, then we just increase the risk for our own staff and for our community. So ask a travel history. Anyone who's having infectious symptoms, they don't have to have a fever, but just make sure that they haven't traveled. Now, it would be really the Swiss cheese model that you get an unexpected special pathogens patient to your emergency department. We've created a public health structure where a patient, wherever there's an outbreak, those patients are funneled when they come into the US through 5 specific airports, Dulles being one of them. And then we take their information, and the local Department of Health for their terminal destination or their final destination will be monitoring them for 21 days. If they were to have symptoms, they would then get referred directly to a biocontainment unit. And so it would completely bypass the ED. But there's always that chance of that patient who gave, a wrong phone number, or just gets lost to follow up, or doesn't think to talk to the Department of Health and just presents to a local emergency department. And we just need to be ready to find those patients. So ask your travel history. Always ask your travel history. And then you may ask, well, Lauren, okay, I asked the travel history, and this person who has a fever said, they were just in Barbados. Now what do I do? Is there like any outbreaks in Barbados? How do I get up-to-date information? And so there's this website here, the CDC one is my favorite for looking up international outbreaks. It's nice because it actually has a drop down for the country. So you just click on the drop down, you find the country where the person has traveled, and it'll give you any travel alerts or advisories, plus whatever is an endemic to that country. So super useful website. This graph here that I have is actually what we post in our triage rooms at Washington Hospital Center. I just like to have a kind of a running list of our outbreaks for our staff. And actually MedStar has its own health travel history and disease of concerned list that's posted on Starport, which if you go to the infection prevention tab on Starport, you can get their most up-to-date list there as well. But if anything, just copy that CDC website because it's a really great resource. If you Google CDC travel advisory and the country of concern, that will also bring up what you're looking for. But if you just Google Democratic Republic of Congo outbreak, you're not going to get what outbreaks are actually going on. So you really have to go with that CDC link to be able to get the most up-to-date information. All right, so you've identified. Next is isolate, and this also is so simple but so difficult. Our EDs are busting at the seams. We have patients everywhere, and so you need to identify them and then just put them in a private room, preferably a negative pressure room. Get them out of the hallway, number one. Get them out of the waiting room. That's harder than it sounds sometimes. And then really, it's all about staff safety in this next step. So minimize the people that are going to the bedside. MedStar has decided learners stay out of the room. Now, that does not mean they can't be involved at all in the care. They can be part of that medical decision making, but just keep them away from the direct bedside care and wear the appropriate PPE. So for viral hemorrhagic fevers, full skin coverage is the way to go, which is why we tend to prefer the PAPRs and suit combo, because it's much more comfortable than having an N95 with a tight fitting hood and making sure that all of your skin is covered. But just be careful and slow when you get into the PPE and out of the PPE. You should always have a protector, someone who's observing you go through the motions to make sure that you're doing it safely. All of our PPE is a little bit clunky. There's no real national standard as to what ensemble to use because they're all a little imperfect. And your ensemble may be different from what we're doing at Washington Hospital Center. So just slow, careful, safe is the mantra. It's most important that you stay safe in this process. We're all heroes, but this is a scenario where I don't want you to be the hero and running into the room unprepared or unprotected. Third step, last step, inform. How do you reach out to us? How do you get one of these special pathogens cases over to the RESPECT? Well, you contact us through the good old MTC. So I think you all probably know this number by this point, but just call the MTC, ask to speak with the ID attending on call at Washington Hospital Center. It's helpful if you say it's for a highly infectious disease patient or a special pathogens patient, an Ebola patient, any of those kinds of terms will trigger them to know who to call. But essentially it's the ID attending on call. They'll talk to you. They're going to want to know where was the patient, when were they there, what contacts did they have, any sort of risk factors that they could actually have been exposed to a special pathogen. And then they will arrange for potential BCU activation if they're still concerned. That process is multi-step. We're talking about relocating an entire unit of patients, bringing in an entire new care team. So it's not without a heavy decision to make that. So it does take us a little bit of time to make the call. But the goal would be to activate our BCU within 2 hours and get the patient in the room for care within 8 hours. That's what I got for you. So just remember that travel history. That's the biggest thing. Your task is to identify these cases, isolate them, and then reach out for help, and just be safe in the process. Thanks.